Hello everyone, this is Ahmed Abdelrahman. Today we are going to talk about arrhythmias in the USMLE Stop 2CK. So let's start with the normal electrocardiogram or normal ECG. When you set the ECG device to the normal speed or the usual speed, which is 25 millimeter per second, one large square will be equal to 200 millisecond. And this means that the small square will be equal to 40 millisecond because one large square constitutes about 5 small squares. So you'll divide 200 millisecond by 5 and it will be 40 millisecond, which is equal to one small square. And to calculate heart rate in ECG, you will divide 300 by the number of large boxes between the two R waves, or you can use another equation which is the same thing, which is 1500 divided by the number of small boxes. So the normal heart rate in adults is from 60 to 100 beat per minute, and heart rate below 60 beat per minute is bradycardia, and if the heart rate is above 100 beat per minute, this will be tachycardia. So rate is the first thing to check when you are reading an ECG. Second thing to check is rhythm. So the normal rhythm is a sinus rhythm, which is originating from the SA node. And to say that the ECG has regular rhythm, there should be an equal distance between the R intervals. So sinus rhythm originating from the SA node, and the P wave should be upright in leads 2, 3, and AVF. And it should be inverted in the AVR lead. Also, the P wave will precede every QRS complex. So this is the rhythm. So the first thing we check rate, second thing we check rhythm, third thing you check intervals. And you have three important intervals to check, which are PR interval, QRS interval, and the QT interval. So the PR interval, as you see in the photo, is its normal value is about one large box, and the QRS interval normal value about half of the PR, which is about half large box, and the QT interval will be about normal. It will be normal until 2.5 large boxes. So again, the PR interval will be until one large box, and the QRS interval will be about half of this large box or half the PR, and the QT interval will be normal until 2.5 large boxes. You should check these intervals to see if they are prolongated or not, and to check if they are very short or not. So these are the three things that you check to find arrhythmias: rate, rhythm, and intervals. So let's start with bradyarrhythmias. As you see in this photo, we can start by trying to detect which is type of bradyarrhythmias this is. So first thing, as we said, let's check the rate. So we will divide 300 by the number of the large boxes between the R intervals. So it will be 1, 2, 3, 4, 5, 6, about 6 large boxes. So 300 divided by 6 will be 50. So this patient is having a bradycardia. Second thing, let's check rhythm. And to see if it has regular rhythm, let's count the boxes between the R intervals and let's see if they are equal or not. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So this is regular rhythm, and also you can find that the P wave is upright in this lead. So you can see that this is a regular or a sinus rhythm. Let's check intervals. So let's see the PR interval. As you can see, we have about 1 2, 3, 4, 5. About 5 small boxes, which is one large box. It's normal PR intervals, not prolongated. Let's check the QRS. 1, 2. Okay, we say that until one half of the large box it will be normal. So this is 2 small boxes, which is normal because half of the large box will be 2.5 small boxes, and this is 2. So this is not prolongated QRS, and the QRS itself looks normal. Third thing, let's check the QT interval. So let's try to count the boxes. It's about it's about two large boxes and about 3 small boxes. So, and we say that QT interval is normal until 2.5 large boxes. So this means that the QT interval is normal too. So this patient is having a bradycardia with normal rhythm or sinus rhythm and normal intervals. So this patient is having a sinus bradycardia, which is because that the SA node is firing very slowly. So what is the pathology behind this? It can be a normal response due to vagal stimulation. For example, if someone is pressing on his carotid during shaving, the vagus will be firing to slow the SA node. It can be due to SA node dysfunction or sinus node dysfunction. It can be due to medications like beta blockers or calcium channel blockers. So the clinical picture of this patient can be either asymptomatic or symptomatic. And if he is symptomatic, he will be having lightheadedness or syncope, and also he can come with chest pain or hypotension. Chest pain and hypotension is associated with right coronary artery occlusion or right coronary artery myocardial infarction, because the right coronary artery is supplying the SA node. So it will cause chest pain when the patient is having myocardial infarction. And when you look at a patient with chest pain and sinus bradycardia or hypotension and sinus bradycardia, you should expect right coronary artery occlusion. And the hypotension happens because the right coronary artery that supplies the SA node also supplies the right ventricle. So the right ventricle will not be able to push blood to the lung because it's infarcted right now. So when the right ventricle does not push blood to the lung, this will lead to less blood coming to the left ventricle, and this will lead to hypotension in return. The ECG of this patient, as we said, he is having a sinus rhythm and his rate or her rate is below 60 beats per minute, and the management will be according to an algorithm that you should remember. So when you find a patient with bradyarrhythmia, which means that his pulse is below 60 and the patient is symptomatic with dizziness, for example, you should assess his or her appropriateness for clinical condition. So you should identify and treat the underlying cause of this sinus bradycardia. You should have an IV access, and you should do a cardiac monitoring to identify this rhythm. And you should put a pulse oximetry with oxygen for hypoxemia. And also you should put 12 lead ECG if possible. And do not delay the therapy. This is very important because of the MCQ. Do not delay therapy. So if the patient is having a persistent bradyarrhythmias and one of the following criteria: hypotension or any signs of shock, for example, if his systolic blood pressure is below 90, or if the patient is having acute mental status changes, for example, if he is confused, or he is fainted. And if the patient is having chest discomfort, like in the case he will tell you that the patient is holding his or her chest, because this chest discomfort may be an indicator for cardiac ischemia, or if the patient is having acute heart failure. For example, if he is having basal crepitations in lungs, which is a sign of acute heart failure in the left ventricle, or if he is having a distension in the jugular veins, which is a sign of heart failure in the right ventricle. So if the patient is having any of these characters plus bradyarrhythmias, because you knew that it's a bradyarrhythmia because you detected that the pulse is below 50, you will give the patient intravenous atropine 0.5 milligram bolus. It's not an infusion, you will give him 0.5 milligram bolus. And if the patient doesn't respond, you will give him another IV atropine 0.5 milligram, and you will do that every 3 to 5 minutes until you reach 3 milligram. Now, if you did that and the patient didn't respond, you have three options. You can either do transcutaneous pacing, which is a pacemaker under the skin, or you can give the patient IV dopamine, or you can give the patient IV epinephrine. And the dopamine and the epinephrine will be taken through infusion. It is not a bolus like the atropine. And if there is no response after you applied one of the three, you should consider an expert like a cardiologist or interventional cardiologist for transvenous pacemaker placement. Now, if the patient is having a bradyarrhythmia but he is not having any character of hypotension, acute mental status change, chest discomfort, or acute heart failure, you will monitor this patient and observe him. This algorithm is very important to remember and to study, and actually if you take an ACLS course, you will study this algorithm. So you can check the rate of this patient by dividing 300 by the number of large boxes, as we said before. So it will be 300 divided by about 6, it will be 50. So this patient is having a bradycardia or a bradyarrhythmia. So we check the rate. Let's check rhythm. So as we see, this is lead 2, so the P wave is upright and there is a QRS after every P wave, and the number of boxes is almost equal between every R wave. So this patient is having regular and sinus rhythm. Now let's check intervals. Let's look at the PR interval. The PR interval at the first wave on the left. Let's count the small boxes. So the small boxes will be about 1, 2, 3, 4, 5, 6, 7, 8, 9. This is 9. And we say that the normal PR is about 1 large box, which is 5 small boxes. So this is 9 small boxes. This is prolonged PR. Let's check also the PR in the next wave. It's also about 9. So this patient is having prolonged PR. Let's check the QRS, it will be normal. Let's check the QT, it will be normal. So the data that this patient is having bradycardia, sinus or regular rhythm, and prolonged PR. And there is no dropped beat or dropped QRS, as there is QRS following every P wave. So this patient is having a first degree AV block. It's because that the AV node is blocking the electrical signal going to the ventricle, so the PR will be prolongated, because the PR is the time between the atrial depolarization and ventricular depolarization. So the ventricular depolarization will be delayed because the AV node is blocking signals from passing from the atrium to the ventricle. The etiology, this can be normal because also of vagal stimulation, like pressing on the carotids while shaving, and it can be due to medications like beta blockers or calcium channel blockers. The clinical picture, the patient actually can be asymptomatic, and this AV block can be found incidentally, and on the ECG there is PR prolongation with no dropped QRS. It's very important that there is no dropped QRS, only PR prolongation in the first degree AV block. And if you remember that the sinus bradycardia, there was only bradycardia, there was no PR prolongation. So how to manage this patient with first degree AV block? If the patient is non-symptomatic, you just observe, and if the patient is symptomatic, you can give him atropine. So let's check this patient again with our approach. So check rate, then rhythm, then intervals. Let's check rate. So we'll divide 300 by the large boxes. It will be 300 divided by almost 4, which is 75, which is normal, right? It's between the first and second wave. But look at between the third and the fourth wave. It will be about 1, 2, 3, 4, 5, 6, 7, and almost half large boxes. So if you calculate the rate between the third and the fourth wave, it will be about 300 divided by 7.5 large box, and this will be about 40 beat per minute. So this means two things: that this patient is not having a regular rhythm because the intervals between the first and second wave is not the same between the third and fourth wave. And the other thing, that this patient may be having a bradycardia. So let's check other thing in the rhythm, which is that there is a QRS should follow every P wave. So first wave, okay, a P wave followed by QRS. Second wave, okay. Third wave, okay. Fourth wave, you can find that there is a dropped QRS beat. So that's another thing that we found. And the P wave is upright because this is lead 2. Okay, so now we checked rhythm. We found that this patient is maybe having an irregular rhythm, and also he or she maybe have a bradycardia or bradyarrhythmia. Third thing, let's check interval. So let's look at the PR interval in every wave. The PR interval in the first wave is about 1, 2, 3, 4 small boxes, which is normal. Let's look at the second wave. Check the PR. 1, 2, 3, 4, 5. That's okay too. Let's check the third wave. 1, 2, 3, 4, 5, 6. That's a prolonged PR. So what happened is we started with 4 boxes, and it became 5 boxes, and it became 6 small boxes. So this means that there is excessive prolongation of the PR, or successive prolongation, and after that there is a dropped beat of the QRS. This patient is having a second degree AV block. Remember that in the first degree we had prolonged PR, but there was no dropped QRS. But here we had successive prolongation of the PR followed by a dropped QRS. So this is second degree type 1 or Mobed's type 1 AV block. So the etiology, it can be due to digoxin. Actually, digoxin stimulate the vagal action and can cause AV block, or beta blockers or calcium channel blockers. And actually it can happen with right coronary artery infarction or occlusion, because the right coronary is supplying also the AV node. Remember that we say that the right coronary is supplying the SA node. That's true, and it's also supplying the AV node. So the patient can come with chest pain and AV block. If this happens, you should suspect that this patient is having right coronary artery occlusion. The clinical picture of this patient, he can be asymptomatic, or he can have like a sensation of palpitation or even syncope. And if it's associated with right coronary artery occlusion, he will be having chest pain due to the myocardial infarction or ischemia. And if you check his ECG or her ECG, he will be having progressive PR lengthening, then a dropped beat. So the management of this patient, how to manage this patient? If the patient is asymptomatic, none. You do nothing, you just observe. And if the patient is symptomatic, you treat the cause by stopping the drug causing this AV block, or treating the infarction or the ischemia behind that, and you can give him or her atropine. So actually it is the same as first degree AV block. So Mobed's 1, which is second degree type 1, treatment is the same as first degree AV block. And let's remember again, sinus bradycardia, there was only bradycardia on ECG when we checked the rate, and every other thing was normal. And when we checked the first degree AV block, we found that the patient is having prolonged PR but no dropped QRS. And when we checked Mobed's type 1 or the second degree type 1, we found successive prolongation of the PR, then a dropped QRS. Now, let's go for this patient and let's have the same approach. Let's check the rate. Divide 300 by the large boxes. 1, 2, 3, 4, 4.5. This is between the first and the second wave. But check the rate between the second and the third wave. 1, 2, 3, 4, 5, 6, 7, 8. Oh my god. 300 by 8. Which is below 40 beat per minute. So this means two things. This patient may be having a bradyarrhythmia, and the other thing that the rhythm is not regular rhythm. Let's check the other thing in the rhythm, which is the P wave is upright. Yes, it's upright here, and this is lead 2, so it's normal here. And the other thing that every P wave is followed by a QRS complex. So in the first wave, yes, a P wave, then QRS. Second wave, yes, P wave, then a QRS. Third wave, a P wave, but no QRS after that. That's an important finding. Okay, so we checked rate, and we found that this patient is maybe having a bradyarrhythmia. Also, we checked rhythm. We found that the patient is having an irregular rhythm. And another thing in the rhythm that there is no QRS in some waves. There is a dropped beat or dropped QRS. So the third thing we should look at is the intervals. So let us check the PR interval. Actually, it's normal. There is no PR prolongation. The QRS is normal. The QT is normal. So this patient is having bradyarrhythmia, and normal PR and irregular rhythm, but there is a dropped QRS. This patient is having a second degree AV block type 2, which is also MOBIDS 2. So in MOBIDS 2, there is no PR prolongation. There is only bradyarrhythmia with dropped QRS beat. And actually, this is because of the pathology of MOBIDS 2. The block in MOBIDS 2 is below the AV node. It's not in the AV node itself. It's below the AV node. So the PR interval will not be prolonged because the blockage is below the AV node. It's in the bundle of Hess and the trifascicular branches that supply the ventricle. So the ventricle already started depolarization, but the problem is that the electrical signal will stop immediately in one beat. So you will have just a dropped QRS and the PR will not be prolonged. So what is the etiology behind MOBIDS 2 or pathology behind MOBIDS 2? It can happen due to fibrosis of the conductive system below the AV node, maybe due to acute or subacute or prior myocardial infarction which caused fibrosis and caused a block in this pathway or this conductive route. The clinical picture, the patient will come mainly with syncope, and on the ECG, as we said, you can find unexpected dropped beat and normal PR intervals. The management of this patient should have a pacemaker. Either the patient is symptomatic or asymptomatic. This doesn't matter, because if you remember in the second degree AV block type 1 and the first degree AV block, our management was dependent on if the patient is symptomatic or asymptomatic. If the patient is asymptomatic, you will do nothing, you will observe. If the patient is symptomatic, you can give atropine. And actually the same in sinus bradycardia. In sinus bradycardia, if the patient is having bradycardia with some of the symptoms like acute chest pain, hypotension, acute mental status change, acute heart failure, if the patient is having any of this, you can proceed with the management, which is giving atropine. And if the patient is not having any of this, you'll just observe and monitor. But here, in second degree EV block type 2 or MOBIDS type 2, you should put a pacemaker. It is not dependent on the patient is symptomatic or asymptomatic, because actually this can cause sudden death. This is very important to remember, and you can find a lot of cases about that on the question banks. So let's check this new patient. Let's check the rate. You can simply find that he is having a bradyarrhythmia, a lot of large boxes there. Let's check rhythm. You can find, if you check between the R intervals, it's actually having a regular rhythm between the R waves. But actually, if you focused, you will find that the QRS wave is having a strange shape. It's not the normal QRS that you can find in the other patients we checked. So keep that in mind. Okay. So let's check rhythm. We say that it's normal. And the other thing we check in rhythm is that there is a QRS following every P wave. So in the first wave, yes, there is a QRS after the P wave. And in the second wave, there is no QRS after the P wave. And in the third wave, okay, there is a QRS after the P wave. And in the fourth wave, there is no QRS after the P wave. And in the fifth wave, actually, you can't find the P wave because actually it's hidden inside the QRS. Okay, so there is no QRS after every P wave. We checked rate. He's fine. He's having a bradycardia with checked rhythm. There's a problem that we can't find a QRS after every P wave, and also the QRS is having a very strange shape. Okay, let's now check intervals. The PR in the first wave is 1, 2, 3, 4. Okay, QRS is almost normal, and the QT is not important here. Okay, let's check the next one. PR interval 1, 2. It was 1, 2, 3, 4 in the first wave, and in the third wave it's only 2. And actually in the fourth wave here there is no P wave. So there is a complete dissociation between the P wave and the QRS wave, or a QRS complex. So this is a third degree AV block. In the third degree AV block, the P wave is not connected at all to the QRS because the AV node is blocking the electricity completely coming from the atrium. So there is now the ventricle is beating alone by its conductive system, and the atrium is beating from the SE node. So actually they are completely dissociated from each other now. And if you checked the distance or the time between the P wave, you will find that it will be equal. And if you check the time or distance between the QRS complexes, you will find that it's equal, but they are not together. The P wave is not with the QRS. They are completely dissociated. And actually, this is very dangerous because this can cause something called cannon waves. Cannon waves is when the atrium and the ventricle contract together at the same time. As you know that when the atrium contracts at the time when the ventricle is relaxed, so the blood will be pushed from the atrium coming to the ventricle. And the valves are open. The tricuspid valve and the mitral valve are open, so the blood will come from the atrium to the ventricle. But here, they will contract together at the same time because there is no synchronization between them. So the mitral valve and the tricuspid valve, especially the tricuspid valve, will be closed. So the atrium, the right atrium, will be contracting against a closed tricuspid valve. So the blood will come back to the jugular veins, and it will cause a huge distension in the jugular vein that you can see by yourself like a cannon. So it's called cannon waves. So this is very dangerous. So this patient with third degree AV block is indicated for pacemaker placement. This is very important to remember. The pathology is, as we said, it's a complete electrical dissociation between the atria and the ventricle. And the clinical picture, the patient can come with syncope, dizziness, acute heart failure, hypotension, and cannon A waves. The ECG, the patient will have a complete dissociation between P wave and the QRS. And the management, as we said, pacemaker placement. So let's remember what we said till now. We had a sinus bradycardia, which is only a bradycardia with sinus and regular rhythm. There is no other things that you can find in the ECG. And then we had first degree AV block, which is bradycardia and prolonged PR. Then we had a second degree AV block with two types, Mobius type 1 and Mobius type 2. In Mobius type 1, we had a successive prolongation of PR followed by a dropped QRS. And in Mobius type 2, we found that the PR is normal, but we had dropped the QRS beat, and we say that this is because that the block is below the EV node. It's not in the EV node itself. So the electricity already came to the ventricle, but the problem that there is a fibrosis or blockage in the electrical or conductive system below the AV node. And then we are now talking about the third degree AV block, and this is a complete block in the AV node, prevented the electricity completely. So the atrium and the ventricle are contracted with no synchronization. So you will have that there is complete dissociation between the P wave and the QRS complex. Now let's check this patient with the same approach, rate, rhythm, and intervals. And the rate here between the first wave and second wave, you can find that this patient is having about his rate will be about maybe 72 or 71. This is between the first wave and second wave, and the same between second wave and third wave. But look here on the right, between this wave and this wave on the right, you will find that there is almost 1.5 large boxes. So this patient was having here an almost bradycardia, then he is having, or she is having here, a tachycardia. The same patient, bradycardia, then tachycardia. Okay, what is that? This is called sick sinus syndrome. Sick sinus syndrome, which is due to destruction in the SA node or the surrounding myocardial tissue. And actually, atrial fibrillation can be associated with this sick sinus syndrome, and which can cause thromboembolism later. The clinical picture: the patient will have syncope or maybe palpitations, dyspnea, chest pain, transient ischemic attack, and or stroke, because as we said, it's associated with atrial fibrillation and thromboembolism. So this will cause transient ischemic attack or stroke. So it's very important to remember that the sick sinus syndrome is associated with atrial fibrillation and thromboembolism. As you know, in atrial fibrillation, the atrium is not contracting, the blood accumulates inside the atrium, which can cause thrombosis because of this stagnant blood and clotting formation, and then this clot will go to the brain, causing stroke or transient ischemic attack. On ECG, you can find tachyarrhythmias and bradyarrhythmias together, and the management, you should put a pacemaker. This patient is in danger because he may be having a thromboembolism at any time. So, sick sinus syndrome, second degree AV block type 2 or Mobius type 2, third degree AV block, all of these patients must have a pacemaker. And also, if the patient is having a sinus bradycardia and he didn't respond to atropine with all doses we mentioned, and he didn't respond to transcutaneous pacing or dopamine or epinephrine, this patient also should have a pacemaker. And the first degree AV block and Mobius type 1, he should be treated with atropine only if symptomatic. So this concludes our lecture about bradyarrhythmias, and we will discuss in the next lectures the tachyarrhythmias. Thank you and have a good day.